Hi, I'm Tony Nichols, and welcome to Chamber Chat. Welcome to Chamber Chat, a program put together by the Salisbury Area Chamber of Commerce for the sole purpose of keeping you informed on what's going on at your chamber. Each month we try to cover divisional topics within the chamber as well as network topics and topics that are relevant to the community at large. This month's program we have with us Chris Hall, the VP of Strategy and Business Development at Peninsula Regional Medical Center. Chris, thanks for joining us.
Thanks, Tony. Appreciate being here.
Glad you were able to be here. Here recently there has been a lot of press given to PRMC. Could you tell us a little more about what's going on over there?
Yeah, as far as the press goes, it's definitely a sad time. There's individuals who were separated from the company, so they were good coworkers, they were great friends, and this is definitely a difficult time. But backing up, kind of going to why we came into this position, unfortunately, it's not unique to Peninsula. This is happening across the state of Maryland, even across the nation. Really what you're seeing, I necessarily wouldn't equate it to Obamacare, if you will,
Sure.
But it's really the tenets of what's happening in Obamacare. It really comes down to three components. They want to improve the patient experience, improve the quality of care at the least costly setting and most affordable setting. And what happened is, the reason why those three tenets came about is healthcare was approaching nearly 20% of the GDP in America. That's an unsustainable cost. So how do you reduce the costs that are happening in healthcare? The largest cost sector is hospitals. So Tony, for you and I growing up, we'd always see a hospital on the street corners or around the communities. Sure. They were these big pillars in the community. They provided everything. They were every service imaginable they tried to provide. They got bigger, they added more beds, but that's not the future of healthcare. Will happen in our lifetime while we're still working? Probably not. It won't go to the extreme. You'll still go to the hospital for emergency care. You'll still go to deliver babies. But in the future, they're going to be more like an ICU. Very sick people will go to the hospital. Because what's happening is more care is moving to the outside. So this is like the new era of healthcare. This is the change in the business model. This is the new reality we're facing. So people are not coming to the hospital like they used to. So there's less and less people coming in.
I've read a few articles that use the term that I think I know what it means, but maybe you can help me with it. It was rebalancing. Is that similar to right sizing, or is that akin to that? But what is rebalancing?
It's really economics 101. It's what it comes down to. So here, let me give you for instance. At Peninsula Regional, back in 2007, not too long ago, there were 371 beds. So now I'll explain how the beds work. But recently, as of last year, we were 317. Just this past fiscal year, we're set up for this coming fiscal year, we're at 288. The state sets our licensed beds. What they do is they look at the volume that you had in the hospital the prior year, and that sets how much you should, the licensed beds are going to grant you for the coming year. So we lost beds going down to 288 for this year. As an executive team, we looked at that and we said, well, based on the trends that are occurring, the number of people coming into the hospital, we really think we should be budgeting for 250. So heading into the new fiscal year, which started July, we went through our operating budgets and made some adjustments. However, going through June, July, and August, a lot of things changed dramatically overnight for hospitals. So while we were making adjustments for less people coming in, federal sequestration occurred. And with hospitals, it's very unique. In the past, the state sets our rates. They tell you how much they can charge. And when the sequestrations happened years ago, they put that into the rates for Maryland hospitals. So that it never really impacted them. They just absorbed it. They didn't do it this year until June 15th is when we found out. That's a $4 million impact to Peninsula.
Well, that was what I was going to say. I hear all these things, so I'm getting some of the reason why it was necessary, but that speaks to, we're talking about things that happened years ago that have just now started affecting hospitals across the nation. So that's the reason for the move.
So they're rebalancing. And so I said, we're 317 last year, 288 this year. We're budgeting for 250. So the question is, what do you need for services that are going to support an organization at 250 beds? It's not the same organization that was 371.
Right.
So over time, that has to come down. What support services? Now, the trick on all this is, what do you reduce that does not impact the care at the bedside? That was the number one tenet that the executive team felt was most important. So we did not affect the number of nurses that care for a patient, the number of techs. So that care is still utmost importance to the organization.
That makes sense. I want to go back to something you just talked about. I was smiling in my mind when you said, as we were growing up, the hospital's the pillar in the community, big building on the corner, and we look at Peninsula Regional, pillar in the community, big building on the corner. But you talked a little bit about this new reality, how a hospital may not necessarily be the hospital, as it were, that we grew up with. Can you talk a little more about that? You talked about moving to other facilities.
Yeah, here on the Eastern Shore in Salisbury, and even around the three lower counties and beyond, we've always known it as PenGen. It was always the hospital that was, where South Division came into it, and then over time it's grown. So if you look at the campus today, there are buildings on that campus that are from the 30s, from the 50s. The building I work in, the Ed Center, that's in the 60s. And then recent expansion out onto Carroll Avenue and 13, so you have those in the 70s. Another expansion in 90. So you hear some criticisms. Well, you're spending all this money on building buildings. Buildings become obsolete.
Right.
You do have to maintain your facilities.
Sure.
And the interesting thing is, all of us in the community kind of demand private rooms. We demand the highest technology.
Right.
So buildings had to get bigger to handle that. The ORs, that expansion that's happening right now. Do you know those ORs were built in the 1970s?
I would have never.
They were in the 400 square foot range. Maybe one, I think, was right around 600 square feet because of the trauma and the open heart. But those rooms were built in the 70s for the codes and the standards and the technology of the 70s. Technology today, there's a lot more monitors in there. Da Vinci robot has to fit into some of those ORs. Standard today is 600 to 800 feet minimum. So we had to make those expansions because buildings, I heard this from an engineer one day, and I love the word, obsolete. After a while, buildings will become obsolete. So yes, you have to do rebalancing. Now, the trick is, going forward, it's not all going to be inside the hospital. So the PenGen of the past isn't the Peninsula Regional Medical Center of the future. So we're not just a hospital. We have to become a healthcare organization. So that's the new era of healthcare.
Gotcha. When you said, everybody wants their private room, fortunately, I've not had a lot of surgeries or the need to be in a hospital. But the people that I have visited where there was a semi-private room versus a private room, and there is a stark difference, and everybody prefers that private room. Completely understand where you're coming from there. Tell me what a licensed bed is.
Yeah, like I was mentioning, the state of Maryland regulates licensed bed. Really, a licensed bed, simple way to put it, a head in a bed. It's literally a bed with a head wall that has oxygen in it and suction and things like that. So the state comes back and says, this is how many you have to operate, and that's all you're allowed. If more patients come into the hospital than what you're licensed for, you have to seek an emergency CON, certificate of need, to get extra capacity to handle those patients.
Gotcha. Makes sense. I know I've read several articles, and it doesn't appear that this rebalancing or right-sizing is unique to PRMC. Is this felt across the board, across the country?
Yeah, actually, a simple way, go onto Google and just type in hospital layoffs and watch what comes up.
Really?
Go around the state. I can tell you Frederick Memorial announced a number of layoffs. I think it was in the neighborhood of 50. Western Maryland Medical System on their website has a press release, 95 that they've done in 2012. Hopkins is in the process of layoff. Anne Arundel just did a right sizing. They asked each of the department to reduce 6% of their operating expenses as well as a reduction. St. Agnes, just talking to the CEO the other day, they just went through a layoff. It's across the United States. Even McCready, 5-bed hospital, they just laid off about 18 not too long ago.
Well, with the legislations that are kicking in and the cutbacks and pushing these procedures out of the hospital that aren't necessarily life-threatening, how does this impact the organizations? I would assume across the shore and across the nation, as well as PRMC. How does that affect you financially?
It makes it very tough. The bread and butter of a hospital is an inpatient stay. Outpatient stays are a little bit less on the reimbursement for the inpatient. That's where the majority of the revenue is located. So as the number of inpatients are going down, it's less revenue. Less revenue, you have to rebalance your organization for the size that it is. Now, the thing that's happening is it's all heading to the outpatient. In the state of Maryland, the hospitals are regulated, meaning that the revenue that they charge, the state tells you how much you can charge. So they regulate that revenue. On the outpatient, things outside the hospital walls, the state doesn't really tell you how much you can charge. So that becomes more of what's happening in the marketplace. So these services are now going outside.
Is it a sign of a a more health conscious society, or is it what's the reason for the lower admissions? You've just talked about a 20% reduction in licensed beds. Mm-hmm. What's the reason for the lower admissions?
There's a multitude of reasons. You can look from, for instance, at Peninsula Regional, we're what they call an ARR hospital, admission readmission. So all hospitals get penalized. Even in the state of Maryland, you get penalized for readmission within 30 days. So for instance, you went to the hospital, you had your knee replaced, everything went well, your stay went well, you healed properly, you went home. On the way home, you had a motor vehicle accident. Mm-hmm. You get readmitted back into the hospital because of that motor vehicle accident. We get zero reimbursement, all cause, meaning any cause. If you're back within 30 days after a hospitalization, we do not get paid for it.
I heard that, but I didn't believe it.
That's true.
Yeah.
Maryland is the only state that's all cause. Wow. So answering your question, you say, why are they not coming into the hospital anymore? Readmissions. We are working very hard to keep people out. Chronic diseases are one of the most reasons why people come back into the hospital. Diabetics, chronic heart disease, things like that are causing people to constantly come back into the hospital. So what we're doing is we're providing care management out in the community, working with the primary care doctors, working with others, even an individual taking a little bit more ownership in their health. So readmissions are down. So they're not coming back in as often as they used to. In addition, the economy did really put an impact on those seeking elective procedures. Even if you had the insurance, there's a little bit out-of-pocket expense, and people aren't willing to do that, so they're holding off on that. So people are getting healthier. Care First, here's a great example. Care First, the payer, has what they call a patient-centered medical home model. About 3 or 4 years ago they started, and they're working with the primary care doctors, and they looked at their panel of patients, and they said, you got some really sick patients up here. These are the ones using 80% of all the costs. We're going to provide you a care manager, an extra help. And if you use it, we'll give you some money every month to help you out with that. So of course the doctors want that. So what they're doing is now they're managing those sick and chronic patients better. Care First came back and said after about a 3 or 4 year trial, it saved tens of millions of dollars. Wow. That's patients that used to come into the hospital. That's wild. It's a good thing. Don't get me wrong. Yeah. But it's bad for hospitals.
Sure, I understand. It's good for people, bad for the bottom line.
Exactly. So that makes the question, what is the new era of healthcare? What are hospitals going to be in the future? Again, it's going to take some time to play out because we're kind of 1 foot on the dock based on how we're paid today, 1 foot into the boat, which is the future, which isn't where the revenue source is just yet, but it's the right thing to do.
Gotcha. We'd like to remind you that you're watching Chamber Chat on PAC 14. We'd now like to give you an opportunity to take a look at some upcoming events with the Salisbury Area Chamber of Commerce. Welcome back to Chamber Chat. We're chatting with Chris Hall, the VP of Strategy and Business Development at PRMC. Chris, we spoke earlier about this right sizing, or what was the terminology we used? The
rebalancing.
Rebalancing. That's exactly right. What's happening with these people? Are they being laid off, or are they finding new opportunities? What is the hospital doing to assist these people in finding their next home?
Yeah, what I was mentioning is we were going through this rebalancing. We have to decide what is the right support structure for this 250-bed hospital that we're kind of Peninsula Regional is today. So what are the right support services? So those individuals, the positions were eliminated. They were no longer really needed to support the new hospital going forward. And again, I'll talk a little bit more about the outpatient in a second. But as far as those individuals, those 58 positions went away. So the 58 people were sitting there. Luckily, we do have about 80, I think it's about 83 as of today, positions open if you go to our website. Okay. So those individuals have a chance to reapply, and they usually get first choice since they have been as long as they're in good standing. Sure. They have a chance to reapply back into the organization. We do have a number of them have come back. Now, one of the things that the medical center has done that's a very compassionate way, which didn't have to, is they offered a voluntary early retirement package. Gotcha. So they looked at individuals and they said, we made a cutoff and said if you're 62 years of age and you have 15 years of experience, we have a number of individuals that have been there for a long time, and provided dedicated service. So we tried to find a compassionate way on voluntary basis. So some of them overlapped with those positions that were identified for reduction. Majority was 132 positions for early retirement, voluntary.
Right.
If you choose it, great. If you don't, no problem.
Sure.
So as those individuals, and by law they have 45 days to elect whether they want to accept that package or not. So as that unfolds, more positions are opening up. So those individuals where the positions went away have a chance to reapply.
Gotcha.
A number of them already have. Several weeks ago, or a month ago, we closed our transitional care unit, our TCU. Those staff also have had an opportunity to reapply for positions both here at PRMC but also in the community. The transitional care was more of a therapy unit.
Sure.
So after you have surgery, you can, like say knee replacement, you're going to go there for, to recuperate and to get some therapy. A lot has changed over the years as far as what kind of requirements on the inpatient stay, but also what is needed to be admitted to that type of unit. So as those were changing, and the TCU was developed before Genesis had the excess capacity that it had, and before Health South was built out there off of Route 50. So that unit was came into creation. Gotcha. So over time, it became a duplication of services in the community already offered. So a hard decision was made, and a business decision was made that we had to close that unit. So those staff went into some of the other long-term nursing homes, also went to Health South facility, but some were also hired back into the medical center. So some are separated, some are come back.
It's always good to hear that in a scenario like this. It's always hard to eliminate a position, because when you eliminate a position, you impact an employee, a family.
Correct.
Sure. In the same vein, in eliminating the positions, whether they be administrative or clinical, I would think as important is the care of the patient. What is your plan, or what is PRMC's plan to make sure the care provided to that patient isn't impacted during these times of
absolutely.
turmoil?
One of the tenets as we went through, in the time, it was over a several-week period that the executive team went division by division, department by department to make that assessment. What was necessary going forward, what was a must-have. One of the things that never changed was the care at the bedside. A great example, on the med-surg units, which is a typical unit, medical surgical unit that a patient would go to, the ratio is 6 to 1. There's 6 patients to 1 nurse. That did not change. The level of staffing never changed. Staffing was never an issue on the decision by saying we don't have enough staff, we can't staff it. We always have plenty of staff for the bedside. The care will not change. So if you're coming in for an obstetrical procedure, for delivery, you're coming in for the emergency room, plenty of staff, care will never change.
Well, that leads into my next question, and quite frankly answers my next question, in that what does all this mean for me? I get sick, or it's 1:30 in the morning, and
1:30 in the morning, you have an emergent issue, you're going to call 911. You're going to take care of it just like you always have. And I don't think that'll ever change going into the future. However, it's 5 p.m. and a child sprained their ankle at soccer practice. You may not be going to the ED. Some people still do. You may be going more to the urgent care at a lesser center. Speaking on that outpatient side, one of the things that Peninsula decided years ago was not to own all these other businesses out in the community. For instance, home health. Adventist Healthcare, where I came from, owned a home health agency. Peninsula decided it's not its core business. Their core business was Peninsula Regional Medical Center, but they partnered with those. The nursing home is another, as I mentioned before. They partnered with them. There were 6 partnerships out in the community between surgery center, durable medical equipment. So those other providers are out there. The third tenet of that triple aim was most appropriate setting. We have to reduce the cost of health care, so we have to go out into these other settings.
Gotcha. When do you see this rebalancing being complete?
We are no longer going to see the number of layoffs that we did as we went through this process. So we are now complete with the number. Going forward, though, into the future, it's hard to say, and I cannot make a promise to anybody that things are over. The rebalancing has to occur all the time. So you have to look at the medical center and say what services are needed at this time. So that's going to be an ongoing discussion.
Well, I think to ask Peninsula Regional Medical Center to be able to look into the future would be as inappropriate as asking me in my business or anyone in their business, because you don't really know what tomorrow brings. As things are pushed out to the ambulatory surgical centers, the outpatient looking a little different, what becomes of the hospital? Talk to us some more about Peninsula Regional Medical Center 5 years from now.
Peninsula Regional Medical Center, I think, is a part, actually, it's interesting, even today, Peninsula Regional Medical Center is a member of the health system.
Okay.
So there is a Peninsula Regional Health System, and that health system now has these 6 joint ventures that I was just talking about a little earlier.
Mm-hmm.
In addition, there's the site in Millsboro, Delaware. That site will have primary care physicians, specialty care, and other services, diagnostics, maybe even walk-in urgent care, maybe community pharmacy. So you're going to see centers like that out into the community where people live closer to their house in a cheaper, more affordable setting.
Gotcha. I've also heard about waivers that could be put in place for Maryland where you could receive more reimbursement monies. Tell us about that.
As I was mentioning how Maryland regulates the licensed beds that we have,
yes.
Maryland also regulates the amount that you're charged. Back in the 70s, I think it was 1977 to be exact, they came up with a waiver program. What they did is they say, all right, not like the rest of Maryland, not like the rest of the United States, Maryland's going to be unique. We are going to reduce the cost that it costs Medicare to provide care in Maryland. So they came up with a system that capped and managed the cost over time. However, recently there's now 3 separate methodologies that they pay hospitals.
That's
Here
right.
on the Eastern Shore, we have Peninsula Regional under what's called an ARR, readmission. You have Atlantic General that's under charge per case, and you have McCready that's under TPR, total patient revenue.
Mm-hmm.
And the way total patient revenue works is they say, oh, you spent $100 million last year or had $100 million in revenues. We're going to give you $100 million. You figure out how to spend it.
Okay.
So that's how that is worked. Charge per case at like Atlantic General, they get incentivized to have more volume. The more volume, the more people, they get paid every charge. They get paid a charge for every case that they have.
Gotcha.
So they have, whereas we have these penalties imposed if we have extra readmissions. So not only do we not get paid, like I was talking about, all cause, we get a penalty on top of that. So to compare one hospital to another in the state of Maryland is almost impossible because they're separate payment methodologies. Just last week, the Rate Commission put forth another waiver that they're sending forward to the governor for signature to go to CMS, the Centers for Medicare and Medicaid, as a new waiver. And now the new waiver is matching very similar to what you see with the Affordable Care Act. Better quality, better experience at a cheaper and more affordable setting.
Wow. All right, it's time for you to put your crystal ball in hand. Take a look into that crystal ball and tell me what you envision Peninsula Regional Medical Center means to this community, healthcare in general. Where do you see all this going?
First question I would answer, or way I first answer that, is the Peninsula Regional Medical Center on the corner of Carroll and 13,
Mm-hmm.
it'll still be there.
Okay.
We've been there for 116 years. We're positioning it now for the next 116. Will it look the same today? Will the buildings be as large? Probably not. I think we have to maintain facilities, so that's why some of those parking lots are there. So you have a chance to as buildings become obsolete, to replace them with facilities. But Peninsula Regional Medical Center will still be in Salisbury into the future. In addition, the Peninsula Health System, some type of health company, will be throughout the community, similar to what it is now, but even in a bigger scale. So as we're in Millsboro, Delaware, up in Laurel, Delaware, Ocean Pines, down in Chincoteague, Snow Hill, we have offices and locations all around the Delmarva Peninsula. Mm-hmm. I think you'll see much more of that and out into the community.
Chris, we could talk for hours. But I think it's about time to wrap this up. Is there anything that you'd like to share with us as you part ways?
You know, as I mentioned, you know, everything we've done historically to this point, everything going forward will always be about the patient. The Peninsula Regional Medical Center's mission is to care for the community and improve the health of the community. So as we make the decision and the rational decision that we're not just a hospital, but we're a healthcare company, we'll make sure that mission is always carried out.
Chris, thanks for joining us.
Thank you.
Well, that's a wrap on this edition of Chamber Chat. As always, we encourage you to visit PAC 14's website and utilize their video on demand feature to view this episode and other episodes as well. You could also see it on the Chamber's website utilizing the blog that the Chamber has called The Voice. Again, I'm Tony Nichols, your host, encouraging you to make a difference.